This week on the BackTable podcast.
And the surgeons that were in the CT control room were basically planning right there and then how to crack open the chest and try to get this wire out.
Wow.
And Ivan was like, hold on. And they'd already done like a cut down in the neck and tried to grab it, but it wasn't there anymore. So it was now somewhere in the IVC. And so Ivan was like, hold on, guys. I think we may be able to do something about this. Like, he wasn't sure because, he hadn't done this before, but he was like, okay, let me talk to Dr. Newsom. So he went over, he was like, Dr. Newsom, is there anything we can do about this? And she was like, yeah, of course. And one of the nurses that came there with her actually happened to bring a snare with him. So we had one snare. And so she just got IJ access and picked the wire out. And there was like 30 people in the room. Like the surgeons were there, the emergency department were there, and like it was like for them it was like absolute magic. Okay, yeah. How someone can just like go in and pick the wire out, in a matter of minutes. And yeah, I think that really goes to show the kind of impact that IR can have.
Hello, everyone, and welcome to the BackTable podcast, your source for all things interventional and endovascular. You can find all previous episodes of our podcast on iTunes, Spotify, and on BackTable.com. Before we dive into our topic today, just wanted to say a word from our sponsor, Medtronic. The New England Journal of Medicine has published big news for AV fistula patients. Learn more about the IMPACT AV Access trial to see how the IMPACT AV drug-coated balloon can affect reintervention rates for patients with kidney disease. Visit medtronic.com/AVDCB for more information. This is Aaron Fritts as your host this week, and I'm very excited to introduce our special guest today, Dr. Fabian Laage Gaupp. Welcome, Fabian.
Hi, how's it going? Thank you so much for having me.
Sure. So we've been excited to have you on. We got connected through a mutual friend, and I was able to learn more about your project, the Road2IR. I'm going to let you talk a little bit more about the Road2IR, but I did want to have you give us a quick introduction about yourself, where you're coming from, and where you're at.
Yeah, so I'm Fabian. I'm the current chief resident in interventional radiology at Yale New Haven Hospital in Connecticut. I'm originally from Munich in Germany, and I moved over here after medical school in 2015 for my training, and have been here ever since.
Great. And so tell us a little bit about, the story of how you first got involved with Road2IR, and then we'll kind of get into what's unique about it and the how the program's organized.
Sure, yeah. So I'll have to go back a couple of years for that when this program really first got started. So back in 2017, when I was a second-year radiology resident, I was always like very interested in global health, but I didn't really know how to go about it with combining it with interventional radiology. So when I was a second-year resident, one of my faculty, Dr. Frank Minja, who's a neuroradiologist and who's originally from Tanzania, asked me if I wanted to join him there. So he's been going there every half a year, and he usually brings along some fourth-year residents. And one of the fourth-year residents that year couldn't go with him on pretty short notice due to a family emergency. So Frank reached out to me because he knew I was interested in global health and asked me if I want to join on short notice. And I said, yeah, of course I want to come. So I went there with him. And my goal for that trip was essentially to figure out like what's the status of interventional radiology in Tanzania. I didn't really have any idea, and also Frank didn't really know. He wasn't aware of anything. So our assumption was that there's probably not much going on. So I went there for 2 weeks and did a little assessment, basically seeing what's currently being done. And to sum it up in a nutshell, there was essentially nothing. There's not a single interventional radiologist in Tanzania, and there was nobody doing any image-guided procedures. The only thing that they were doing was the pathologists were doing FNAs in CT, but they weren't really using CT to guide them. So they weren't using the laser grid. They weren't using like a radiopaque grid to find the entry point. They did a CT scan, and then they basically just stuck the needle wherever they thought it could be. And then they did another CT and checked where it was, and then they adjusted and at some point sort of got into the lesion. But like I said, only FNA, nobody was even doing core needle biopsies. And we're talking about like the national hospital of a country with 60 million people. Okay, so that's a 3,000 bed institution, nobody doing core needle biopsy, nobody doing abscess drainages, nobody doing nephrostomies, nobody doing biliary drains, nobody, let alone doing like UV or anything for that matter. So that was basically the status when I first got there. And while I was there, I met 3 really amazing residents there who were also second-year residents there at the time, Eric, Ivan, and Aza, who now have become really great friends and sort of my partners in this whole project. And we basically decided, okay, we have to get IR started in Tanzania. And since there was no interventional radiologist in Tanzania, we figured, okay, we have to bring the expertise there. So as it was done with my 2-week stay there, and we were like sort of going back to the airport, I was talking to Frank in the car, and we said, okay, if we do this, like we basically have to do it big. Like we can't just go there every half a year and do a little bit of IR, because that may work in diagnostic radiology, but in interventional radiology, you need the hands-on training, you need continuity of care. If you do a procedure, let's say you put a nephrostomy to someone, chances are that tube is going to get obstructed, and you can't really have a break for half a year without anyone being there to take care of it. So our goal was to send 10 teams to Tanzania per year and to start training the first generation of interventional radiologists, and also start training nurses and technologists together with the residents. And that's basically what we did.
So that's really interesting. So it sounds like originally you were going over there just to provide general radiology services and training. Is that correct?
Yeah. So Frank has been going to Tanzania. I mean, he grew up there, and then he moved to the States for his medical training and residency. But after finishing residency, since he's been attending, he's been going there every half a year. And since he's a neuroradiologist, he was focused on teaching neuroradiology. And he went, like I said, every 6 months, and sort of just gave courses there and started instilling some of that specialized neuroradiology knowledge, because at the current time, there weren't any subspecialty training programs in Tanzania. So everyone just trains 3 years as a general radiologist.
Yeah. And that's interesting. So at the time you're general radiology resident.
Yeah, exactly. I was in my second year of training there. So, I mean, I'm an IR resident. So I did 3 years of diagnostic radiology and then 2 years of interventional. So now I'm in my second and final year of interventional radiology. But yeah, at the time I was just a second year diagnostic resident, essentially.
But you knew you wanted to do IR at that time.
Yes, exactly.
Yeah. That's really a neat story, because you saw this need there, and you had what sounds like really enthusiastic and smart residents over there who were interested in not just general radiology, but IR specifically, right?
Yeah, exactly. So those 3 that I mentioned, Aza, Ivan, and Eric, they were all really passionate about IR. And it was really, I don't know, I guess a fate in a way that we met and sort of were able to, work together on this, because for them at the time, they didn't really know how they were going to get their IR training. So one of them, Ivan, is actually from neighboring Rwanda, and they don't have any IR in Rwanda either. But he actually moved to Tanzania for his radiology training, because he figured that there his chances of learning some IR are a little bit greater, even though they didn't have IR training at the time. But just because it's a bigger country, he figured maybe he can somehow learn some IR. So yeah, all of them are like really extremely passionate. And it's just been really fun working with them and sort of like growing this together over the past 3 years. So, and I'm in my final year of training here now, and they are in their final year of training there. And so we're basically all graduating next year.
And so how did they know about IR as a specialty when they were in this IR scarce situation?
Yeah, just from reading about it in books and online. They had watched like YouTube videos and read books about it. And so they knew a good amount, but they had never done anything. And so that's where we started, really from absolutely nothing. So when I was there the first time, we actually did sort of the first image guided procedures, and the very first procedure we did was actually lung biopsy, and we didn't have a radiopaque grid. So Eric came up with an idea, and he said we can just use like a chicken wire, and we just put that on the patient and use that as the radiopaque grid, and that's how we did the first image guided lung biopsy.
Wow, that's pretty cool. Yeah. And so I guess fast forward, you guys put this program together and the rest of us all heard about it in the December 2019 JVIR, where you guys co-wrote the article, Tanzania IR Initiative, Training the First Generation of Interventional Radiologists, which stated basically, despite a population of nearly 60 million, there's currently not a single interventional radiologist in Tanzania. And it also, you guys, gave some numbers just as a reference. In the US, there's more than 100 radiologists per 1 million people, of which approximately 10% are considered IRs. In contrast, in Tanzania, there's currently only one diagnostic radiologist per 1 million people. And so that's, obviously very inspiring to try and get something going. And so since its inception, can you update us on the progress that's been made, and also can kind of maybe delve into how the IR training program is organized?
Yeah. So, obviously, when you're starting from nothing, it's pretty easy to make progress because any progress is progress. So in that sense, we have really made a lot of progress because, like you were saying, like not even the most basic things were being done, like abscess drainage. It's hard for us to imagine that someone would show up with a huge, let's say like a pelvic abscess or like a perforated appendicitis and would not have the option of a simple image guided drainage, right? It's just hard to imagine here. Yeah. But that was really the reality. You have like kids there with like huge liver abscesses, and the only option for them is open surgery. And open surgery there is not like open surgery here. There, we've encountered patients that had open surgical procedures, and they basically make an incision from the sternum down to the pubic symphysis and just go and take a look, because they sometimes do surgery without prior imaging. So we had like one patient, for instance, that came with liver cysts, and she had like a prior surgical drainage, and they opened her up, like I said, from top to bottom just to drain a couple liver cysts. So anyways, so that's basically where we started. So, and what have we done since? So we've sent 14 teams to Tanzania. The first teaching trip was exactly 1 year after I went there for the initial assessment. So that was in October 2018, when I went there with Dr. Silvan, who's the IR program director at Yale. And we brought with us a nurse and a technologist. And then we've done one trip since every month, pretty much until February of this year when COVID started. So we had to cancel all subsequent trips until now. And we're actually planning on restarting trips now in December. And in terms of the progress that's been made, so we've done about 450 procedures so far over the past now 2 years. And while that isn't a lot, if you compare to an IR department here, it's a lot more than the 0 procedures that were done prior to that. We also now have like a dedicated IR section there. And most importantly, we have the first accredited IR training program in all of sub-Saharan Africa. So, outside of Egypt, there isn't a single IR training program in all of Africa. So not even South Africa has an IR training program, which is hard to imagine, but it's a reality. So they all go abroad to train. And as you can imagine, not everyone has the means to go to, let's say, Singapore or Turkey or the US to train. So you essentially have over 1 billion people in Sub-Saharan Africa who don't have access to IR, and they don't have access to IR because there's no IR training. And now we have 3 fellows in their second year. So it's a 2-year fellowship. So they do their 3 years of diagnostic radiology, followed by 2 years of interventional radiology. So we have currently 3 fellows in their second and final year, and now 6 incoming fellows in their first year. So we have 9 fellows. It's a pretty big program by now, and it's really been growing exponentially.
And can you tell us a little bit about how so you told us it's a 2-year program. Can you kind of break it down? I guess we get into the types of cases they see shortly, but is there, separated by, are they on rotation for CT guided procedures versus vascular procedures, or is it all just kind of you show up that day and they do whatever cases are on the board?
Yeah, it's more like that, because when we started in 2018 with the training, we started with only basic percutaneous stuff. So it started with like corneal biopsies, abscess drainages, nephrostomy, biliary drains. Those were the 4 procedures that we focused on first. And then we sort of started slowly adding to that. So, now we've started doing uterine fibroid embolizations, splenic artery embolizations, central venous access, like dialysis catheters, Hickmans, PICCs, etc. So no, we're not really separating by rotation. They just do whatever comes along. And it also depends on the faculty that go there. So often faculty that go there will have a specific goal to get something started. So when Dr. Newsome from Emory went there in June of last year, she was the first to introduce uterine fibroid embolization. And she went there with a goal to, try to get that started. And similarly now, Dr. Vin Takur from Florida, who's going now in December, he wants to get a PAD started. So he's bringing the appropriate equipment, and they're already right now starting to recruit appropriate patients. I actually just got off a phone call with the residents there and Vin, and he wants to start doing some arterial work and do some angioplasties and stenting. So yeah, in that sense, we really just do what comes along, and obviously you can't plan for everything. And if there's an acute urinary obstruction or biliary obstruction, of course we're going to do it. So in that sense, it's kind of similar to IR training here. At Yale, at least we just do, whatever comes along, and depending on what room you're in, you're just going to do those cases.
Right. And obviously COVID has kind of put a wrench in the gears. You already mentioned with traveling volunteers. How has the program adapted from that February to, you say you're kind of reinitiating traveling in December? Have there been Zoom lectures, webinars for the trainees? How have you guys adapted to that?
Yeah, exactly what you're saying. So we were always doing some Zoom teaching even before, but we sort of increased that, so that currently I would say on average we have like 2, sometimes 3 Zoom sessions per week with various faculty that have been to Tanzania. So they will sort of often do like board review style sessions where it's just them and the Tanzanian fellows like reviewing cases or doing little quizzes. But then we have WhatsApp groups. One WhatsApp group specifically is dedicated to like sort of quizzing the Tanzanian fellows. So some of the US faculty will just post an image and say, okay, what's this? What's the differential? What will you do about it? And so that's how most of the teaching has happened since COVID started. Yeah. But we're also working on some more sophisticated ways of supplementing teachings. For instance, we've started filming procedures at Yale using a 360-degree camera, and we send like an Oculus headset to Tanzania so that they can sort of immersively review cases. So we're basically filming just like basic stuff like PermCAT, Hickman, like all that stuff, just for them to reinforce that and learn those steps. Because now that they didn't have any visiting teams for all that time, they've started doing more and more procedures by themselves. So like biopsies, nephrostomies, biliary drains, they're doing independently now on a daily basis. And they've also started doing central lines independently. And the next step is basically for them to start doing uterine fibroid embolizations and other procedures of that nature, even when there's no visiting faculty there. And they're extremely quick learners. And I mean, we recently actually analyzed the data so far from those 450 procedures. About 25% were done independently. And the technical success and the complication rates are actually slightly better for those procedures done independently, probably because they're playing it a little bit safer. So they're not doing any crazy stuff when there's no one there, no faculty there. But overall, it's like extremely encouraging because they're doing so well even alone.
Yeah, it sounds truly like see one, do one, teach one. And
exactly.
I'm sure much like our predecessors, we had Ernie Ring on and David Cumpy on recently to talk about history of IR stuff. And those guys kind of were forced to be innovative and just try things out and see what helps the patients. And so I imagine it's these residents and fellows are getting to experience some of that over there.
Yeah, I have to say those episodes with Dave Cumpy and Ernie Ring were absolutely spectacular. I mean, I loved it. Actually, when I listened to the one with David Cumpy, I sent it. The first thing I did was I sent it to the residents in Tanzania, and I said, that's exactly the mindset we need to have.
Yeah,
you need to have that pioneer mindset. Like, you can't be afraid. You have to really come up with new solutions. And yeah, I mean, that David Cumpy, that was just amazing, man. What a career. And like, I mean, the stuff he came up with, it's just really mind boggling.
Yeah. And he was rooted in Germany too. He did that stent in Germany and look at how much, I mean, that experience taught him and really laid the foundation for him to to be so innovative.
Exactly. And I think it was so beautiful to see how sort of like the international collaboration, like when he went to Switzerland, he picked up something new, he brought it back to Colorado. And I think really that spirit that he talks about, this like innovation and sort of like the pioneering and the excitement that he had, like with every time he did a new procedure, that's exactly sort of what we're going through in Tanzania right now. Like those first three fellows are really the pioneers for their entire nation. For them, they've like 60 million people sort of in a way depending on them learning this stuff. So I mean, it's a lot of pressure in a way, but it's also really exciting. So, and I think that all of the faculty who've been to Tanzania so far really sort of get that sense of excitement, because here often when you work in academia in particular, I guess you're sort of bogged down with like a lot of the day-to-day stuff, and you don't even realize what you do as an interventional radiologist, like how amazing it is. And like when you go to Tanzania, you see that magic of IR, that you can really make a difference with every single procedure.
Yeah, that's very exciting. And so question is, the fellows that are finishing up this year, will they stay on as faculty and help teach the future fellows, do you think?
Yeah, so that's the plan. So like I said, one of them actually is from Rwanda. So he's going to move back to Rwanda. So he's graduating next year in September. He's going to move back. And then we're actually planning on starting an IR training program in Rwanda next year in October. So he's already preparing for that. So he's already like sort of in negotiations with the health ministry in Rwanda, sort of how much they need to support him. And they're already building an angio room and starting to order equipment, etc. So that's going to be really exciting. Rwanda, well, it looks like a small country on the map. It's actually 10 million people. So also not irrelevant.
Yeah.
And he's a really amazing guy. And I think he's going to do a great job getting an academic training program started there. But then for the Tanzanian trainees, yes. So our plan is essentially that at least 2/3 of every class sort of stay in academia. And of course, some people are going to go and like, open private practices and go to other hospitals. And that's totally fine. But as long as we're sort of retaining 1/3 to 2/3 of residents, which is not going to be an issue, because actually a good amount of the trainees there are sort of like state-sponsored trainees. So they basically have to stay in the public health system.
Oh, gotcha. And obviously it takes more than just MDs to treat patients. Can you tell us a little bit about, and teach, can you tell us a little bit about the dedicated nurses and technologists that have also volunteered for this project?
Yeah. So, I mean, as you said, they are absolutely essential. I mean, as like you can't do any IR procedure without a technologist and a dedicated nurse. So, and we knew that from the start, which is why on every team we make sure to have at least one nurse and one technologist with us. And currently we're training 4 nurses and 3 technologists in Tanzania. And they're doing a great job, so that by now actually we can send teams sometimes without a nurse and technologist. Like that's okay, because they're so well trained by now. And actually 2 of the nurses, they are currently undergoing moderate sedation training with anesthesia, because when we first got there, the nurses didn't have any experience with moderate sedation because they were just diagnostic radiology nurses. So they didn't have to sedate anyone. So they're learning that from anesthesia now, because currently we have anesthesia there for every procedure to administer the moderate sedation. But then going forward, we're hoping that that's no longer going to be necessary. So they're going to get a certificate for moderate sedation. So that's I think a great, step forward in giving the nurses there some independence.
Yeah. And are there any other groups of physicians, like interventional cardiologists, vascular surgeons, or oncologists, anybody that you guys have traveled over there with that help supplement in terms of the training?
Not really. So the way you have to think about it, it's a huge hospital there. It's like a 3,000 bed institution. So, I mean, it's like way bigger than Yale New Haven Hospital. And they actually have like pretty good care overall. So they've like sophisticated surgical services there. They've started doing renal transplants recently. They're about to start hepatic transplants. They have most of these subspecialties, and certainly there have been a lot of foreign institutions involved in building that over the past few decades. So, for instance, Emory basically built the emergency department there, and there's a university from Norway who's been involved with building the orthopedic department there. So yes, there are other groups that work there, but most of them are sort of more advanced than where IR was when I went there. So
Right.
We're not really directly coordinating with anyone, but clearly I think that other sections there are very happy that IR got started now, because you can imagine, especially when you have like a transplant center, I mean, how can you do anything,
Right.
without IR? I mean, like or not every complication, but a lot of the complications have to be addressed by IR.
Yeah. And along the same lines, in terms of what they have available, what imaging equipment do they have? And then sort of what were you guys able to bring over, and maybe touch on what their needs are in the future?
Yeah, so what they have, when I went there, I was actually sort of pleasantly surprised in terms of the imaging equipment, because they have a 64 slice Siemens CT scanner. No, actually not. They have a 64 and a 128. The 128 is sort of the main hospital where we are, and the 64 is at a different hospital. And that's really state of the art Siemens somatome with the laser mark and everything. So really, really great. In terms of fluoroscopy, so we're using a C-arm, which is decent. It does DSA. And soon we're actually going to get a dedicated angio room. So that's going to make things a lot better. I mean, currently we're doing everything on the C-arm, which is fine, but it could be better. And in terms of ultrasound, they have great capacity. I mean, they have a ton of ultrasound machines and really good ones. So no issue on that. But then where the problems really start is when you're talking about disposable equipment. So obviously, when I first got there was nothing, not even the most basic drainage catheter. So on the first trips, we really had to bring everything with us. So every team that goes there, every person tries to bring at least one box with equipment. But then we're working on really starting procurement by the hospital there, so that's underway, and we're actually in the process of making the first big order. Big is, I guess, relative, but we're talking about about $100,000, and that's going to probably last for several months. So we're making progress, but disposable equipment is really a huge challenge, as you can imagine.
Yeah, and so in terms of disposable equipment, have you gotten much in terms of funding or resources from the device industry for disposables?
Yes, I mean some, but obviously not enough, because it could never be enough. But I have to say, I mean, for instance, Cook gave us a good amount of equipment when we first started. Gurbet recently gave us like 20 vials of Lipiodol because we want to start doing some taste. So yes, we have gotten support from different companies. Also, Burlington Medical donated about 20 leads, so we have more leads than we need now. So yes, we have gotten support, but the issue is really that we can't build a sustainable program based on donations, right? So what we really need is more companies to also start selling their products there. And so far, Merit and Argon are the only two companies that are willing to ship equipment directly to Tanzania. Okay, so that means like Boston Scientific, Cook, and many other companies, they don't have distributors in Tanzania. And that's a bit of an issue, because it means you can't get that product, or at least you can't get it for a decent price. So the way to get it then is to buy it through South Africa or through Egypt. And of course, that causes an increase in price by sometimes more than 100%. So, they will sell you like a Benson wire for, I don't know, $50, which is crazy.
Right.
And we'll try to sell like an Amplatz wire for $80, $90 or even more, and simple biopsy guns. So I'm really hoping that as the program continues to grow, more and more companies will sort of start to see the value in expanding to Africa. Because like I said, there's like 1 billion people without access to IR, and I'm telling you, it's going to explode. There will be such high demand, and these training programs are going to start popping up all over Africa. And only basically Africa is where the US was in the 70s, right? And you know how quickly IR sort of developed from the 70s to the 90s and then to now. And the same thing is going to happen in Africa, if not faster.
Yeah. And so how can a trainee, whether it be resident or fellow or an IR in practice, get involved, whether it be obviously volunteering your time, but are there other ways that we can get involved?
Yeah, so like I said, the most obvious thing is going on trips. And I think that's sort of what most people enjoy the most. I mean, I certainly love traveling, and it's always a great time going there. And everyone that that has gone, which is by now over 50 people, has really said that it's been like one of the most amazing experiences that they've had. And people have described it as really like life-changing, just because you have a great time and you really have an impact. But yeah, anyone can get involved on any level. And the good news now is that we actually this year got an RSNA grant, Derek Howard Nash International Scholar Grant, over $74,000. And all that money is essentially going to travel. So I'm now able to pay for everyone's trips. In the beginning, we had to rely on donations and people chipping in themselves. And now we can provide everything. I can pay everyone's tickets. We can provide housing. So it really, I think, makes it a lot smoother, the whole operation, because for the first year or so, we were constantly struggling and running out of money. And so now we don't have to worry about that anymore, at least for a year. But, people that, especially now with COVID, maybe don't feel comfortable traveling internationally, can get involved with giving lectures and can get involved with, just being active in the WhatsApp group, sharing interesting cases, helping with organization, helping with research. And we do a ton of research projects. We have a research call every weekend where we have at every time probably at least 10, 20 research projects ongoing. A lot of them are led by medical students, but of course we need faculty to oversee those research projects. So there's really a lot going on, and everyone that's interested can get involved at every level.
And for those that, like, let's say I'm concerning volunteering in 2021, how long are those trips lasting? So
usually people go for 2 weeks. That's the ideal time, because 1 week is a little too short, and especially because it's such a beautiful country. You really want to do a trip over the weekend. So usually over the weekend, people go to Zanzibar, which is, just amazing, like amazing beaches. You can go snorkeling, the dolphins and everything. So, it's just beautiful. Other people go on safari. Tanzania has amazing national parks. So it's just, I think, a good idea to stay for 2 weeks. So usually people fly in there on a Sunday, get some rest, and then sort of get started on Monday, do procedures Monday through Friday, and then go on safari or Zanzibar over the weekend, and then same thing for the second week, and then fly home on the subsequent Friday or Saturday, and then get back to work at home the following Monday.
And with COVID, are we looking at quarantining in either like either when you get there or when you get back? Do you know the restrictions on that?
Yeah, so in Tanzania, you don't have to quarantine when you get there, but we require that people that fly there get COVID tested within 72 hours of departure and have a negative result before traveling. Because my biggest concern is actually bringing COVID there, because, as you can imagine, there's a lot more COVID in the US than there is in Tanzania. It actually hasn't been a big problem in Tanzania so far. So that's my biggest concern. So I really want to make sure that people don't bring COVID into Tanzania. And then, of course, I would advise people to wear an N95 on their flight, and also while they're there, basically the same precautions as here. My personal opinion is that I don't think we should shut down all global health efforts because of COVID, because, COVID is a global phenomenon. And these disparities continue to exist. And actually now they're getting worse because of COVID. So there's really, in my opinion, no reason to just put all global health projects on hold. And I think we sort of have to start getting active again, but of course doing it in a smart way. So the same precautions that I apply when I'm here at Yale doing procedures, I would apply there. So a typical day there now, so in the beginning it was just percutaneous procedures, but a typical day there now is basically a really nice mix of procedures. So let's say you would start off with doing a bilateral nephrostomy in a young female with metastatic cervical cancer with urinary obstruction. Then you would go on to put a biliary drain in a really nicely dilated biliary system, where you can get a nice left-sided access with ultrasound. We do a lot of biliary stenting. And then in the afternoon, you could have, like, let's say, uterine fibroid embolization or a splenic artery embolization. So a typical day, we do, I would say, anywhere from 4 to 6 procedures. And then every now and then you sort of have like the odd case come along. So for instance, when Dr. Newsom was there last year, one of the residents, Ivan, was sitting in the CT room, And he was actually just pulling up some images for a different patient. And he sort of just noticed in the background that they're scanning something interesting. So he looked over there and was like, what's going on there? So the surgeons were in the room there, and they were scanning a patient that someone had lost a wire in. So this like first year resident in the emergency department apparently dropped the wire in the patient when he was placing a central line at bedside. And the surgeons that were in the CT control room were basically planning right there and then how to crack open the chest and try to get this wire out.
Wow.
And Ivan was like, hold on. And they'd already done like a cut down in the neck and tried to grab it, but it wasn't there anymore. So it was now somewhere in the IVC. And so Ivan was like, hold on, guys. I think we may be able to do something about this. Like, he wasn't sure because, I mean, he hadn't done this before, but he was like, okay, let me talk to Dr. Newsom. So we went over, he was like, Dr. Newsom, is there anything we can do about this? And she was like, yeah, of course. And one of the nurses that came there with her actually happened to bring a snare with him. So we had one snare. And so she just got IJ access and picked the wire out. And there was like 30 people in the room. I mean, like the surgeons were there, the emergency department were there. And like, it was like, for them, it was like absolute magic. Okay. Yeah. How someone can just like go in and pick the wire out in a matter of minutes. Yeah. And yeah, I think that really goes to show the kind of impact that IR can have, like this minimally invasive procedures that are currently just not available to 1 billion people in sub-Saharan Africa.
Yeah, talk about a great way to get the rest of the surgeons on board with building an IR program for them to see that. That's awesome. Well, any last comments before we finish up?
No, really want to thank you guys for having me, and I really want to invite anyone who's interested in this to reach out. And there's a lot to do, not just in Tanzania, but in all of sub-Saharan Africa. So I would really encourage people to also get new partnerships started with universities in other countries. Like I said, we want to get started in Rwanda next year, but the same situation applies to Uganda. The same situation applies to the Congo. So, there's many, many countries in sub-Saharan Africa, and all of them need interventional radiology really urgently. And I think that we've sort of developed a successful model, and I would be really happy if people want to copy that and want to apply it in other countries.
Yeah, well, kudos to you and your team, and what a worthy cause. And I'm really excited to see the whole program continue to grow. And will you guys be publishing any data in JBR to follow up the original article?
Yes, so we're actually in the process of submitting that. So like I said, we have about 450 patients now. So we're about to submit that. So hopefully they'll be coming out within the next couple of weeks or months.
Awesome. Again, to our listeners, thank you for listening. And we will have links to the Road2IR in our show notes. Fabian, also, just if people wanted to follow what's going on, what are the social media handles?
Yeah, so it's Road2IR. So Road and then number 2IR. And there you can really see a lot of what's going on. I mean, we try to post there pretty frequently. We're on Instagram and Twitter and Facebook. But yeah, so if you really want to get an overview, just check out the Instagram. You can sort of see what's going on there.
Okay, awesome. Thanks again, Fabian. Keep up the good work, and looking forward. I'm hoping that I'll be able to make one of these trips here soon.
That would be great. Thank you so much.